And again, I'm Jens Chapman, and we have the University of Missouri today. Scott, do you want to say hi from Texas?
Yeah, greetings from Plano, Texas, from TBI. We're excited to have the participation from the Neurosurgery Department, University of Missouri today.
Great to see everyone. Thank you for having us. Dr. Chapman, Dr. Blumenthal.
Good morning.
Good morning to you. So, Ravi, Dr. Siddiq, do you want to just say hi to everybody and tell everybody who you are? And today's topic is a particularly cool one because it shows an approach technique which falls into the less invasive or minimally invasive category, the far lateral approaches. And this is, good morning, Rick. This has taken the device technology certainly by storm and has become a mainstay in the literature, and there are a lot of questions about it though also. So we just had a lateral course here with the big inventors of this, and we had many discussions as to how this technology has evolved and where it's going to go. Certainly a lot of compelling aspects in terms of anterior column release and reconstruction. Ravi, do you want to take it from here, or?
Yeah, absolutely. So I'm Ravi Nuna. I'm a PGY 6 in the Department of Neurosurgery at the University of Missouri. And like Dr. Chapman said, I think we've selected an assortment of articles that compare and contrast the usage of the lateral procedures, both in deformity correction and degenerative spine. And then Mike will go over some approach considerations and some of the anatomy of the approach. I'm going to share my screen here. Are you guys able to see that?
Looks great.
Great. So this first paper is clinical and radiologic analysis of MIS, anterior posterior combined surgery and deformity surgery. And this was published in 2024. It's very recent. It's from the Kansai Medical University in Osaka, Japan. They do a lot of spine surgery there, and it's a retrospective series. Overall, corrective adult spinal surgery, deformity surgery has demonstrated improvements in pain and quality of life. I think we have, numbering in the thousands of papers in the literature now that support adult deformity surgery. MIS deformity surgery is a newer option that individuals will employ, and some of the literature says that it minimizes blood loss, wound complications, and potentially other operative complications. One of the main techniques is circumferential MIS deformity surgery, and that's usually using either an A-lift or an X-lift or O-lift, along with T-lifts for interbody placement and then subsequent percutaneous pedicle fixation. And that circumferential MIS deformity technique is essentially what this series used in their study. So the authors began usage of the O-lift approach for L1 to 5 interbody placements back in 2012. And then in 2015, they began using the O-lift also for L5-S1. Previous to that, they were using predominantly T-lift approaches to instrument and place interbodies at L5-S1. So they had a change of practice in 2015. So overall, they wanted to compare and contrast both clinical and radiologic outcomes of an L5-S1 O-lift versus an L5-S1 T-lift when used as a part of an MIS deformity correction procedure. And they defined an MIS deformity correction procedure as any procedure where the entire fusion construct spanned from the low thoracic levels down to the pelvis. Overall, they had 117 total patients. 82 patients underwent L5-S1 T-lift, and 35 patients underwent an L5-S1 O-lift. The average age was 76, and there was a multi-stage correction in all patients. For the T-lift group, the first stage was an L1 to 5 O-lift, and these were all instrumented with a P cage, and then they used DBM and bone marrow aspirate. And in the second stage, they did a mini open L5-S1 T-lift with a single 18-degree lordotic cage. And then they did percutaneous pedicle fixation, and then from the low thoracic, and used S2AI screws for pedicle fixation, also using cortical screws. In the OLIF group, the first stage, instead of just L1 to L5 OLIF, they went ahead and also included L5S1 and performed an OLIF at that level. 1 to 5, they used the same kind of peak cage with DBM and bone marrow aspirate. And then at L5S1, they had some variability in the cages that were used, either a 10, 12, or 18-degree P cage with integrated screws into the implant. And in the second stage, again, similarly, they did pedicle fixation from low thoracic to S2AI, pelvic screws. These were just some of the pictures that they included in their study. They didn't include any pictures of their TLIF, but this was one patient with a pretty significant coronal deformity, as well as a loss of lumbar lordosis. I think measured 4 degrees prior to surgery and 54 degrees postoperatively, and they normalized the PILL mismatch as well in this case. Again, this is all done, quote unquote, MIS. This was just another example that they gave. This total procedure time was about 6 hours. Preoperative Cobb angle of 63 degrees. That was corrected to 7 degrees after postoperatively. And the mismatch of 54 degrees was corrected to close to 2 degrees. So clearly some fairly impressive results using these hybrid MIS techniques. So overall, in terms of their results, this is a table that they included for their baseline demographics. So you can see 35 patients in the OLIF 5-1 group and then 82 in the TLIF group. Similar age, gender, weight, height, BMI, scoliosis. You can see here that they both had sagittal imbalance measuring almost 15 centimeters. Both had fairly high pelvic tilts, way greater than 20. And then a lot of flat backs, lumbar lordosis, a little bit under 10 in both groups, and then these huge mismatches in both cohorts, almost 40 and 45 degrees in these groups. Average follow-up time was 41 months, and then one of the immediate analyses that they did was a comparison of operative time and blood loss, finding that both operative time and blood loss was decreased in the OLIF groups versus the TLIF group. And this is a very busy slide, but this was the radiologic analysis comparing OLIF 5-1 and a TLIF at 5-1. And most of these are about the same. And you can see that the post-op pelvic tilt did improve to less than 20 in both groups, but the differences were not statistically significant. Again, the follow-up lumbar lordosis was 10 and improved to greater than 40 on average. Again, not statistically significantly different between groups. There was a difference in terms of what they call the lower lumbar lordosis. So between L4 and S1, as you might expect, the OLIF group had greater lower lumbar lordosis. And again, probably as you'd suspect, just from the dimensions of the cage and the kind of disc prep that you're able to complete, they also demonstrated a greater segmental lordosis in the OLIF group. You can see that it was 20 degrees versus about 16 degrees. And then another interesting factor is that they also looked at the coronal tilt just at L5 and S1, and they found that there was less in the OLIF group, as you might also suspect, just given the dimensions of the cage, in that it was more of a balanced segmental correction in the OLIF group. And then this was one of the outcome measures that they used. They used the Japanese Association of Orthopedics outcome measures to assess pain, low back pain function, gait, social, and psychosomatic. And it's hard to explain, but in most of these groups, the OLIF group did seem to perform slightly better, and those differences were significant. And on visual analog scale, however, though, there's no differences based on low back pain, lower extremity pain, and lower extremity numbness. These groups are not significantly different when comparing visual analog scales. Overall complications, PJK was slightly higher in the TLIF group, 13% versus 6%. Hardware failure slightly higher in the OLIF group with 5% versus 8%. And the OLIF group did include one major complication, which was intraoperative fat embolism. So overall conclusions of this article, the L5-S1 OLIF may be associated with comparable overall radiologic and clinical outcomes. Radiologic, when we look at a global assessment, particularly when used in deformity correction procedures, that an OLIF overall will give you similar levels of lumbar lordosis, similar correction of pelvic tilt and PI-LL mismatch in comparison to an L5-S1 TLIF for this very particular usage. However, if you form an OLIF instead of a TLIF, you may have lower operative time, lower blood loss, and then you may have segmental lordosis that is better using an OLIF as opposed to a TLIF cage at that level.
Ravi, thank you. Can I just start interceding? So thanks for that article. I did not know that journal, but I have two very basic questions. So, and then I want to ask our TBI colleagues who are masters at beautiful anterior surgery. So when I look at this data, and I did not look at the source article, I must admit, the two things that strike me are, number one, the p-value chase, that chase for a p-value that may not reflect clinical meaningful differences. So when I see numbers of 1 to 3 degrees difference, I was always taught that measurement error is between 3 and 5 degrees, so that falls within a barely perceptible thing, despite best intentions and non-bias of every evaluator, especially when you talk about deformities, osteophytes, end plate irregularities, yada, yada, yada. So for me, although technically less than 0.05 is 3 degrees, and sometimes it was even 1 degree, really meaningful. So I'll put that out there. Number two, for all these deformities, we do a lot of deformity surgeries here. The humbling thing is not necessarily on the first 3-month x-ray. The humbling thing is 2 to 3 years later, when they break their rods, they fall apart, there's a non-union. Something is broken, and that's usually at the lumbosacral junction. So how long was their follow-up? So that's my question to you. And then I want to obviously pass off to our colleagues at Texas Back Institute.
Yeah, so absolutely. So to your first point, I completely agree. I think that's the main limitation of this study is the sizes of these cohorts. Number one, but these groups are not clearly not powered to actually even detect what may be a difference between groups. And in addition to that, the groups are just so small. So, this is a retrospective series, and I think that they may suggest some associations, but, the differences, again, may be mild, and I think part of what they can claim from this article is that, an L5-S1 OLIF may be at least as good as an L5-S1 TLIF. In terms of the radiologic outcomes, if they're clinically significantly different, I think that's hard to say, and I would suspect the answer to that is probably not. Like you said, the segmental lordosis correction, even just between those two levels, it's so small. I would suspect, as they found, that actually global lumbar lordosis was not different between the groups. So I think to your point, I think that's exactly accurate, and I think their follow-up time was about 41 months. So pretty reasonable follow-up time, average follow-up time.
So our TBI colleagues have developed a mastery of arthroplasty and have brought this to our shores. And along that line, they have kind of perfected the clean, clear, anterior, not just approach, but release. So my question to you, Scott and Rick, is OLIF versus a proper anterior approach. Is there a big difference in your eyes? Is there something that makes this O part of the approach, the O approach, so much superior? Can you get the same kind of a release from that kind of an approach? Is this a marketing gig?
Well, not only is it a marketing gig, it's also one where the spine surgeon generally does his own access, and that's economically we take a hit using access surgeon for an anterior. The comment I was going to make is, at least at our place, a TLIF is used only when there's a contraindication to an anterior procedure, because we don't feel like you can get, number one, the disc clean out, the footprint of a cage, or the lordotic correction posteriorly as you can anteriorly. So, OLIF or ALIF, I think it's just a better correction, and obviously multiple papers have shown that compared to those little cages you put in posteriorly. So that would be my comment.
Thank you. How do you want to
And I just want to add one thing, though. You know, the old papers don't necessarily have all the latest technology. With the new technology of the expanding cages, I mean, I've seen some pretty impressive T-lifts that are slowly bridging that gap of being able to fill up the disc space like we can with the A-lift. We're not there yet. And also the clean out, I think that the surgeons are getting better and better. So I think at some point, we'll get there. And it is a desirable approach just because a lot of people don't have great access surgeons that we have. And I understand why guys don't want to do it if they don't have great access surgeons. So I think technology will help make us better, though.
Yeah, but interestingly enough, the papers that do show improved correction, with these expandable cages posteriorly, their follow-up is their post-op X-ray. We want to see what it looks like 6 months, 2 years down the road, but because you do lose correction.
Dr. Siddiq, do you use access surgeons at the University of Missouri or this O approach, the O approach? Is that something that you leave to the surgeons to do, the spine surgeons?
I think Dr. Siddiq is actually not in yet. I think he's actually attending to some emergency.
Okay. So are you all using an access surgeon, or is this something that you do yourselves?
So for A-lift procedures, 3-4, 4-5, 5-1, we always use an access surgeon. We generally consult either our vascular surgery or our trauma surgeons for assistance with an anterior approach. For our lateral procedures, if we're doing an O-lift, anywhere from T12 to L5, we will not use an access surgeon. We have not, in the Department of Neurosurgery, we haven't done a 5-1 O-lift yet. But I think the Department of Orthopedics is, and they'll do it themselves without an access surgeon.
Oh, yeah. Yeah, my thing is that, again, what I've learned from Dr. Geyer, Dr. Blumenthal, Dr. Ziegler, is the art of doing a quality anterior approach is also directly reflected in the art of doing an anterior release. And there is a very big incremental learning step in doing just that. And that's, again, when I hear less invasive surgeries, I'm never sure that this really benefits the patients outside of the marketing aspect and maybe a 1 centimeter smaller incision. But the release part, here's Dr. Ziegler again, is just an art and a beautiful thing to see when you see masters like the 3 colleagues from TBI that are here doing it.
And Jens,
Yeah,
if
Jens.
if you have a really great access surgeons as we do, it's really no different than doing the O-lift approach. And they talk about the little incisions with our access surgeon in particular, Sandy Moore. She does such a beautiful exposure. I mean, nothing is cut. She goes in between the rectus. Once she finds a plane, it's not quite, us doing a little lateral incision, but still the patients go home. We did 2 yesterday. They're both going home in less than 24 hours. We could do them as outpatients, but we haven't gotten to that point yet. So it really is, it's a minimally invasive approach. You don't go into the abdomen, you're staying extraperitoneal. So.
And Jens, I would say the carpentry is much more straightforward from an anterior or a good anterolateral approach than it is even in the best hands through a T-lift. I think the masters of T-lift probably get results that are equal the average or the average plus anterior spine surgeon. But I think for general use, we revise a lot more T-lift non-union than we ever do A-lift non-unions. And that's in a place where we do a lot of primary A-lifts, and we rarely have to go back for a non-union. But we have pulled a lot of floating T-lifts out from the front and revised them with A-lifts.
Cool. Robbie, do you want to go for the next article?
I think Dr. Ortiz here is going to go over some surgical technique.
Hi, Dr. Ortiz.
Good morning. Sharing my screen here. All right. So for this morning, I wanted to discuss the surgical anatomy of lateral approaches to the thoracolumbar junction. And this paper really struck me as a fascinating read from Dr. Uribe's team at Barrow. And it really goes through, it's kind of a complex, kind of unconventional paper. They do some anatomic dissections They describe the anatomy of the thoracolumbar junction, and then they describe the way that they select their approaches, a step-by-step demonstration of how they execute their approaches. So I thought we'd go over quickly over some of the key factors, key things that we need to get from this paper, and then we'll show a case of a lateral approach we did for an L1 burst fracture, so we can review the anatomy. So really, they did anatomic dissections on 9 fresh frozen specimens, and then took pictures of the anatomy and their approaches. And I think the key points here is that we need to understand the spaces and the layers, right? So we have 2 cavities, our thoracic cavity and abdominal cavity, and these cavities are separated by the diaphragm. We need to think of the diaphragm as a septum that creates the floor of the thoracic cavity and the roof of the abdominal cavity. And the septum is really a concave structure that forms a concave roof of the abdominal cavity. Inside the thoracic cavity, we've got our lungs and our heart. The lungs are invested in the pleura, and the pleura has 2 layers, a visceral pleura and a parietal pleura. The visceral pleura lines the organs, lines the lungs, and the parietal pleura lines the abdominal wall. Conversely, in the abdomen, we've got the peritoneum. The visceral peritoneum lines the bowels, and then the parietal peritoneum lies the abdominal wall. So in between these investing layers, in between the pleura and the peritoneum and their respective walls, there's a potential space. It's almost like the epidural space that can be developed to create an approach to the spine. So the retropleural space is behind the parietal pleura and in front of the thoracic wall, and the retroperitoneal space is behind the bowels and in front of the abdominal wall. So we can do an OLIF approach or a lateral approach to the abdominal cavity, go retroperitoneal, and gain access to the lumbar spine, usually from about the level of the L2 pedicle below, some L1-2 disc below. We can access through the retroperitoneal space. And then above the T11-12 disc, we access the retroperitoneal space. Sorry, the retropleural space. The space in between T11, T12, T11 top of L2, which is our thoracolumbar junction, that's where our diaphragm is. And if we need to expose these levels below T12, we can do that through a retroperitoneal approach with elevation and retraction of the diaphragm. If we need to access the T11-12 disc space, then we need to mobilize the diaphragm. And when we mobilize the diaphragm, we're essentially removing the septum from the equation, and we're communicating both the retropleural and the retroperitoneal spaces. And in order to understand really how to get into the spaces, we need to understand the anatomy of the walls, because these are the layers that we'll go through to gain access to the spine laterally. So we can start with the abdomen. So as we all know, we have our skin, we have our subcutaneous tissue or fat, and then our first layer is going to be the external oblique, and the external oblique is going to have its external oblique fascia. And then the external oblique is running caudally and medially from the ribs and from the bottom 6 ribs medially into the anterior iliac crest, the pubis, and the linea alba. Once we split the external oblique, this layer in between external and internal is where the nerves for the lateral abdominal wall sensation are. So we'll find the subcostalis, we'll find the ilioinguinal and the iliohypogastric nerves. So we need to dissect those bluntly so as to not injure them and get a pseudo hernia postoperatively. We then find the internal oblique muscle, which is running the opposite direction of the external oblique. And the fibers run very opposite, very obvious when we get into that layer, the transition between the 2 muscles. And it's really originating inferiorly from the anterior iliac crest, and it's running superiorly and medially to the bottom 3 ribs. Under the internal oblique, we have the transversus abdominis, which is running transversely, usually a very thin muscle. And underneath, we got the transversalis fascia. And that's kind of the deepest layer of our abdominal wall. Once we open the transversalis fascia, you usually see the retroperitoneal fat, and you're in the space and you can develop it. Conversely, on the thoracic wall, we have similar layers, but we have skin, fat, we got latissimus dorsi over the external oblique. And below the external oblique, we have our ribs and our intercostal muscles, and we got an outer intercostal muscle and an inner intercostal muscle. In between, we have our vein, artery, and nerve, which is on the undersurface of the rib. And what's critical to understand for approaching the thoracolumbar junction is that in the space between the 11th and the 12th rib, we have the transitional space where we go from the abdominal cavity to the thoracic cavity. That's where our diaphragm is. So at the undersurface of the T11th rib, we have the endothoracic fascia originates, and the endothoracic fascia is really a fascia that's inside on the inside aspect of the ribs. It forms part of the thoracic cavity, and this fascia is stuck to the parietal pleura. So to develop the retropleural space, we need to dissect the parietal pleura from the endothoracic fascia. In that same space, we have the diaphragm, which is our septum, which is separating both of our cavities. And when we remove the ribs, we can mobilize all these tissues and develop the planes. So important to keep in mind that the diaphragm is going to be the floor of our thoracic cavity and also the roof of our abdominal cavity. And the transversalis fascia really becomes the diaphragmatic fascia in the underside of the diaphragm. Now, to understand a little bit more of the anatomy, we need to know the attachments of the diaphragm that are relevant to lateral approaches to the spine. And we really have three attachments. So our lateral arcuate ligament is spanning from the 11th rib, spans over the quadratus lumborum and attaches to the TP of L1. The medial arcuate ligament starts at the TP of L1 and spans over the psoas major muscle and confluences into the diaphragmatic crus. And the crude of the diaphragm is the anterior attachment of the diaphragm to the spine. On the left side, it attaches usually, commonly, to the L2 vertebral body. On the right side, it goes a little bit lower to the L3 vertebral body. When we are thinking about approaches to specific disc levels, and this is what's important to understand about approach selection in this paper, is that they're targeting specific disc levels. So if you're going after T12 to L1 disc or L1 to L2 disc, you can usually do that through a retroperitoneal approach with just an oblique angle of your retractor. That usually gives you a good enough view. Sometimes, depending on the patient anatomy, which is somewhat transitional at this thoracolumbar junction, you might need a retrodiaphragmatic approach where you have to mobilize the diaphragm. And in order to do that, you want to bluntly dissect the diaphragm with your finger along the ribs to the L1 TP. And then at the L1 TP, you can very gently, bluntly dissect the attachments of the medial and lateral arcuate ligaments and kind of release the diaphragm. Once you need to get to the T11, 12 disc space, then that's really usually a purely retropleural approach. So having this anatomy kind of fresh and a good understanding of it, we can look quickly here one of our cases, and this is really kind of an educational video that we made for our residents, and we were applying all the concepts that we can see and beautifully described on this paper to manage an L1 burst fracture. This is a middle-aged patient that presented after multiple falls with intractable back pain, inability to stand, and urinary retention. And he had its intact strength and sensation of the lower extremities. CT showed a acute on chronic L1 burst fracture with significant retropulsion, causing near 100% stenosis of the canal at that level with compression of the conus. This is how our positioning, and this is from the Medtronic OLED 2.5 manual, and this is usually how we position our patients. And this is one of our first approaches that we did. So we use a very long incision, in this case, 10 centimeters. Usually nowadays, we'll do this approach through a 5 or 6 centimeter incision. And these are some of our skin margins. This is the superior end plate of T12, inferior end plate of L2, posterior, anterior, and the feet are towards the right side and the head's towards the left side. So this video is kind of very minimally edited and sped up. So you open your skin, use the Bowie for subcutaneous dissection, and at this point we're looking for our landmark, which is going to be the T11th rib, and really the same way that we would use kind of the keyhole as a landmark for arterial craniotomy, for approaches to the thoracolumbar junction, we found that finding the 11th rib is crucial, because this kind of unlocks all the anatomy of the thoracolumbar junction. So we subperiosteally expose the rib. We use Bowie and a combination of curettes for that. And then we remove this rib, and it's important that you go as far posterior as you can so that you have a flat trajectory to a thoracolumbar junction. So we like removing the rib, and then we put it on the bone mill, and we use it for autograft. And we particularly do that for our corpectomies. After the rib is removed, we can see all of our anatomy, and you can see the lung moving under the parietal pleura here, and we'll get a still frame so we can very quickly go through the anatomy. So we've got our diagram. Remember, this is a concave structure, so we can see it here in the center of our field, the abdominal cavity inferiorly, and the thoracic cavity superior to the diaphragm. Now on this next frame, we can see some of the detailed anatomy of the wall of the cavities. So this layer here towards the left side superiorly is the endothoracic fascia. So this is the layer that's attached to the inside of the ribs. And in between this layer and the parietal pleura, which we can also see, is where we can develop the retroperitoneal space, the retropleural space, sorry. We can see our diaphragm, and then we can see the confluence of the abdominal muscles to the underside of the diaphragm. So that's really where we have our intercostal muscles of T11, 12, and the external oblique. So we like to divide those muscles. These are our intercostal muscles of T11, 12. So when we divide them, we gain access to really the transversalis fascia, which is starting to confluence into the diaphragmatic fascia. And we use blunt finger dissection to expose that plane. And then we use a blunt instrument to open, and you can see retroperitoneal fat there. So at this point, we've completed access to the retroperitoneal space. And this patient had a kind of prominent T12 vertebra that was obstructing our view. So we removed, sorry, a T12 rib. So we removed that rib and also used it for autograft. And here we're using blunt dissection to separate the diaphragm. So we're palpating the TP of L1, and we can bluntly with our finger release some of the diaphragm so we can mobilize it anteriorly. And we can also cut the ligaments later. Here we're removing the T12 rib. And by doing that blunt dissection along the diaphragm, we can then mobilize it. And this is kind of the very posterior intercostal muscles there that we're dividing. And lastly, we can then place our retractor, and we get this beautiful view of the thoracolumbar junction. This is a blunt dissection over the psoas muscle. We can see how you can very gently develop that plane. And now this is our view of the thoracolumbar junction. So all the anatomy is here. Now the quadratus lumborum on the abdominal wall, we have the psoas over the spine. This mark here is our L1 TP. You can see the medial arcuate ligament going from the TP of L1 and confluence into the diaphragmatic crus. And then here we can see the underside of the diaphragm, which is the diaphragmatic fascia, which is the continuation of the transversalis fascia. And then you can do standard dissection anterior to the psoas to elevate the muscle and retract them and gain some beautiful access. If you need to go more superior, you can split the medial arcuate ligament, and that'll let you actually bring the diaphragm forward and connect both the retroperitoneal and the retroperitoneal spaces. So here you can see through this incision, we have exposure from the bottom of the T11 vertebrae to the top of the L3 vertebrae. So it gives you kind of a panoramic view of the thoracolumbar junction. And again, nowadays we would use an incision half the size of this to do our L1 corpectomies, and we use kind of 4-centimeter incisions to access the T12 L1 disc space. And this is kind of the cage that we were able to get, our decompression, reduction of the retropulse fragment, and then this was our posterior approach for additional stabilization.
Great stuff. That was a nice video, and thanks to the editing. Now, this is not what I would consider a far lateral exposure, which a lot of the companies sell us with tubular-based surgeries. I'm going to ask Dr. Cliff Pierre to talk about a recent research project that he was involved with about looking at the actual anatomy with a novel twist. Cliff, do you want to briefly outline what you did? Maybe you want to take my seat here, or the camera's panning out.
Oh,
yeah,
yes.
Yeah, you're in focus now.
Thanks for that great presentation, Dr. Ortiz, and good seeing you, Ravi. And Dr. Siddiq, thanks for joining us. Again, my name's Cliff Pierre, one of the research fellows here, and one of our former fellows that from Bochum, Dr. Garrett Lewick, had thought of a creative way to further investigate what type of injuries occur when you're doing the approach that you discussed, Dr. Ortiz. And so what we did was a 6 fresh frozen cadaver study where we wanted to evaluate how far down does some of the diaphragmatic insertions go. And we found it does go down all the way down to about L2-3 disc space, which is concurrent with some of the images that Dr. Uribe's group had shown as well. One of the things that we noticed during the approach that there were no neurovascular injuries, specifically, as well as you demonstrated with the blunt dissection in the videos by the surgeons in your group, as you're exposing that parietal pleura, that was the only thing that we noted. There were no visceral pleura injuries to the diaphragm. However, the parietal pleura was, again, exposed in all of the cadavers that we did the study. Again, we currently have it under review in one of the journals and waiting further feedback from it. But again, one of the things we wanted to closely take a look at is how close are the neurovascular bundles with respect to the approach at the T12, L1, L2 junction. Because again, when complications do happen, they can, be quite traumatic, especially with respect to hernias, abdominal hernias in that respect. So very good review of the literature, Dr. Ortiz.
Thank you.
Hi, sorry, I joined from the wrong link, so I was not in the panel and I couldn't speak. So just to Dr. Siddiq, by the way, Farhan Siddiq from University of Missouri. To answer your earlier question that you asked about access surgeons, so in the earlier part of my practice, I always used an access surgeon for most of the lateral approaches. I was lucky that I was in a practice where we had some really great access surgeons, and our surgery department was very, very well equipped at the time. Then when I moved to Missouri, we unfortunately couldn't find anybody, and for a long time, I stopped doing those lateral approaches. But I do believe that they are really great in terms of restoring the anatomy, restoring the deformity, particularly, but also for fewer incidents of subsidence and better fusion rates, because obviously you get a bigger cage in there, and doing T-lifts for a long period of time, I just don't think that there's any way to put a good sized cage unless you're doing bilateral T-lifts, and then you get into these complicated discussions with the hospital because of cost issues and other things. So then at that point, I think probably a few years ago, and when Mike was doing his fellowship, we had a great colleague in the orthopedic surgery group, through which we decided that we're going to start learning these. So we did some cadaver access approaches, and we are at a point where we can pretty much do any lateral approach from thoracic to lower lumbar. The only thing that we haven't done at this point is L5S1, which hopefully we'll start doing soon. But there is a learning curve. There's a level of comfort that you need to attain, and a lot of my other colleagues are still not very comfortable going through that. But I think it's a matter of applying the knowledge, understanding the knowledge, understanding the anatomy, and then doing some cadaver cases. I think it's really key to understanding this anatomy. And obviously the most difficult part is that L1 to T12, T11 region. Above T11 up to T8, the endothoracic fascia is actually, that's probably the easiest if you have to do. We recently did a 2-level corpectomy. I forgot the levels, but I think it was T9, T8, T9. That endothoracic fascia very easily separates up to T10, 11 level. But when you get to the 11 level, that's where those attachments come in when you're behind the pleura. And but you have enough space to do it without mobilizing or without disrupting the diaphragmatic attachments.
Nice description. Ravi, what do you have next?
Yeah, so sharing my screen again here. So this is a paper in 2021 from the Spine Journal. It's indirect decompression via OLIF for severe degenerative lumbar spinal stenosis. It's a comparative study comparing OLIF directly to the TLIF, published in 2021, again out of Japan and Kyoto, Japan, and it's a retrospective series. So as we all know, there's a number of options for interbody fusion. There's TLIF, PLIF, OLIF or XLIF, and the ALIF. A TLIF with a unilateral facetectomy or a PLIF with a bilateral facetectomy allows for what we call a direct decompression. An OLIF without a posterior decompression, which is somewhat controversial, but there are proponents that this allows for indirect decompression from restoration of the disc height and foraminal height. However, common practice dictates that direct decompression is necessary in cases of severe stenosis, and that's really what I've seen in most places that I've trained. It's always direct decompression for when the thecal sac is severely compromised and stenosed. So the objective of this study was to compare clinical and radiologic outcomes of OLIF with percutaneous fixation, but without posterior decompression, versus a TLIF or a PLIF for severe stenosis and degenerative disc disease. Inclusion criteria was age over 20, 1 or 2 level fusion at either 3, 4, or 4, 5. So they didn't include 5, 1 or 2, 3. At least 1 year of follow-up, and then a stenosis, a Scheizas stenosis grade of either C or D. You can see on the bottom pictured here this stenosis grading system, and they included any cases where of either severe stenosis where you can't see the rootlets, the dural sac is completely effaced, and there's loss of CSF signal within the thecal sac, or extreme stenosis where you don't even see any epidural fat posteriorly. So cases of true severe stenosis. And the OLIF group had 51 patients, 55 levels, and they include supplemental percutaneous pedicle fixation. It was a surgeon's preference regarding implant height and width, and then the usage of iliac crest autograft. The TLIF group had 41 patients and 47 levels, and there was 32 TLIF patients. Those underwent unilateral resection of the facet, but a bilateral decompression of the central canal and bilateral lateral recess decompression, and they used a single banana cage. In the PLIF patients, there was 9 of them, and in this case, they did bilateral facet resection and then a complete bilateral decompression. And in these cases, they used 2 bullet cages. Overall, this was just baseline demographics, and you can see that they're well balanced in both groups, maybe slightly heavier in the TLIF group, but overall, and you can pay particular attention to the grades of stenosis in that the groups, majority were grade C, but there was also about 30 to 40% were grade D, and not very different between the groups. The preoperative characteristics, the perioperative, I should say, that in the OLIF group, again, you see that it does take less time and it does result in less blood loss. However, both groups did have certain complications: ALL rupture in the OLIF, thigh pain, numbness, retroperitoneal hematoma, all are not uncommon occurrences, and then dural tear, and then a pedicle screw malposition in the TLIF group. In the OLIF group, and I think this is the part that was particularly interesting to me, the preoperative cross-sectional area was about 53 millimeters squared, and the post-operative cross-sectional area over doubled from that to a little over 120, with a quite a bit larger standard deviation. You can see pictured here, they have a pre and a post-operative where they just did the OLIF without a direct decompression. And you can see that there is actually CSF signal that you can now see around the rootlets. And you can see on the axial as well that really significant improvement in that severe stenosis. They compared the JOA scores between the groups, and unsurprisingly, in terms of pain scores and disability scores, bowel and bladder function and total scores of the JOA system, they were not significantly different. So in terms of clinical outcomes, they were not able to detect a statistically significant difference between these groups. And in terms of radiographic outcome, and again, this was a small series and not necessarily the purpose of the study, but similar to other literature, they detected a greater rate of cage subsidence in the TLIF group. In this case, almost 25% of the TLIF and about 3% in the OLIF group. The fusion rate was higher in the OLIF group, which I think is consistent with other literature. It was about 87% of the OLIF group, and quite a bit lower in this series for whatever reason, but about 57% fusion rate. And you can see that the cage height, they were also able to get a larger cage height in the OLIF group. So overall, I think the main findings of the paper was that the OLIF without posterior decompression may result in similar clinical outcomes as a TLIF or a PLIF procedure, even in cases of severe stenosis. Indirect decompression via an OLIF is associated with a clearly demonstrable increase in the cross-sectional area of the thecal sac. And then in this limited series, the OLIF was associated with shorter operative times, less blood loss, greater fusion rate, and a lower cage subsidence rate.
All right, thank you, Ravi. So TBI, so Scott, I see your picture on now. How much can you rely on an anterior interbody fusion with distraction to actually achieve a lasting, meaningful decompression, let's say at L4 or 5, without undue subsidence over time? Now this is a Japanese paper again, and having been to Japan several times, they're usually very delightfully smallish patients with not much body mass challenges. So how does this kind of a philosophy apply in a North American setting with a highly diverse and sometimes much more well-fed population?
Yeah, so, obviously our access surgeons would like us to have our patients have a BMI 35 or less, which does eliminate some, and depending on what part of the country you're from, may eliminate a lot. Having said that, this study really reinforces what we have found in terms of the ability to obtain indirect decompression, not only of the foramen with the up-down stenosis, but of the canal itself. And in fact, I've seen papers where it's gotten even a little bit more granular as to, what floor, as McNabb used to call it, the stenosis was in. You wouldn't think that you would be able to decompress the lateral recess by just distracting. And I don't know that you do, but the clinical results, we found that we've had to go back and decompress very, very few patients for this exact diagnosis, L4-5 stenosis with or without, with a degenerative slip. We get really good indirect reduction without being too forceful, just with distraction. As Rick said, very high fusion rate. And, we've gotten more and more bold with more and more severe stenoses over the time, such that, now at this point, we'll give the patients the benefit of the doubt, and very, very seldom do we have to actually go back and do a posterior decompression. So, I think the study kind of reinforces that.
Do you guys ever stage your laterals? Let's say one day you do 2-3 level lateral, and then take a break, let the patient get up, ambulate, see if they have symptoms, and then decide if you just do perc from the back or do decompression plus instrumentation?
Yeah, we kind of approach things differently between the degenerative service and the deformity service at TBI. The deformity guys, I don't know if any of them are on now. It is not uncommon for them to do the anterior portion of the procedure and then determine how the patient does 1 or 2 days post-op in terms of relief of their stenotic symptoms. And if they have good relief, like you said, we'll just do perc screws and not have to do a formal decompression. I'd be interested if they're on to know how often that you can't get a good indirect decompression and have to do a formal open. But I don't know if anybody's on.
So I think it's a really good strategy. I think we need to probably study it a little bit more. I routinely plan to do it in 2 stages. We do the lateral decompression, and then I try to get an MRI overnight to see how much internal decompression we've gotten, and based on that, I decide if the next day is going to be an open or percutaneous. Now, a lot of times, logistically, it's hard to do because getting 2 OR days and then making a decision based on that. 1 or 2 times where I had a little issue was I typically don't like to put a plate on because I want mobility if there is deformity. And in at least one cases, probably 2 cases, where there was significant deformity and we got a really good cage and we didn't put a plate on, and the next day the cage slipped out, and we had to we then had to capture it from inside and pull it back. But we were able to fix it. But that was one of the things that I was a little worried about. I've tried using those half plates so that there is still mobility while we get better correction from the back. But I think a formal study into staging this procedure would actually be very beneficial. In terms of your earlier comment about the weight, yes, we live in Missouri, so weight is is not is an easy thing to manage, and most of our access surgeons have a limit of 30 BMI or something like that, and we never get a patient with 30 or less BMI. But what we have found is that for the lateral approach, if you're doing it, it's actually much easier in people who are big. Because there's a lot of retroperitoneal fat, and as soon as you open those, go through the muscle fibers, you get to the fat. It's a smooth sailing from there. The only drawback is that that fat keeps on herniating into the field, so you may have to put 1 or 2 extra retractors just to keep it away. And then the other problem is that those big people, they will have more subsidence because they just don't lose weight, and the dynamics of the bone density when it's compared to the peak cage or titanium coated peak cage density is so different that they tend to get a little more. So I stress upon, I send them for bariatric appointments before and after, and I keep stressing it. Some of them are successful in losing weight and some of them are not.
Yeah, we're thinking of starting an Ozempic clinic.
Have you started doing prone lateral in Missouri yet?
Well, we talked about a lot. We haven't ventured into it, but I think it's certainly something that we want to. In fact, we're planning to do. I think we're just going stepwise. So the next step will be L5S1, and then the following step after that will be prone lateral. Unfortunately, Mike and Ravi will be leaving by that point, and they are the biggest stimulus for me in particular to improve upon our armamentarium. So I'm thinking about what I'm going to do once they leave.
Ravi, any other articles that you wanted to share?
We did have, if we have time, I think Mike had a quick case, a very interesting case that we did of impingement secondary to a tortuous vertebral artery. I'll pass it off to him.
Do 5 minutes. Is that okay?
Yeah, we can do that.
Go for it.
Share here. Okay, so this is kind of a very unique case, and it's an anterolateral approach to a cervical spine. So this is a 68-year-old lady who showed up with 1 year of neck pain, radiating down the right side towards the lateral shoulder. She had this getting progressively worse over the past year. She had a rotator cuff repair, hoping that that would relieve some of her pain. She had failed conservative therapy, including chiropractic manipulation, oral anti-inflammatories, physical therapies, epidural steroid injections. And then at that point, she got an image of her neck, and on her neurological exam, we can see she had a 4 out of 5 strength of right shoulder abductor, and otherwise she was neurologically intact. So this is an MRI, and this MRI was seen by a provider outside of our institution, and there was a concern that there was a vertebral artery loop causing stenosis of the C5 nerve root. And we can see here this loop kind of going inside the foramen. So this patient had additional workup in CTA, and we can confirm this very large loop indenting and causing very severe compression of the nerve. The patient was then referred to us. We did this formal angiogram and found that she actually had 2 abnormal vert loops, one on the right side at C4-5, and then one on the left side at C3-4. The one on the left side was actually projecting lateral, so it wasn't causing radiculopathy, but the 4-5-1 was very significant and projected medially. Of note, the patient, we did a balloon test occlusion, and the patient passed. So then we debated what to do, and if any of the panelists might want to discuss in a situation like this, what would you guys consider? Would you guys have watched it? We operated, but would anybody else have watched the patient? Would you consider an anterolateral approach for direct decompression, posterolateral approach for indirect decompression? We also saw in the literature people would do a one-level ACDF and put a big graft in, and apparently that somehow reduced some of these loops. Any thoughts from the panelists?
Do you mind showing the CT angio again?
Yes, sir.
Wow, this is like a great pickup. Thank you for sharing that. I'm glad we're doing that. This is why just being super careful about anything. So does this patient have symptoms with head turning? Is there a dynamic flow study like a TCD or something with head turning available?
No, we don't have dynamic studies, and she didn't have worsening
She
symptoms.
did, yeah. In the angiogram we did, and she didn't have. So her only reproducible symptom is on that side when she turns her head, lateral turning. She has more pain in the C5 distribution, but otherwise she didn't have any other issues.
I've seen dysplastic arteries and highly medialized arteries. I'm not aware of having seen a loop like this, so thank you for sharing that. What about our C-spine colleagues for ADRs, Scott, Jack, Rick? Is this something that you've seen before? I mean, this is really scary looking.
No, if you didn't pick that up ahead of time, that would be a bad day in the OR.
I don't know, I'd be a little bit scared right now. In absence of clear symptoms, and you have to remind me of her symptoms again, I'd probably gladly watch her. We have a very nice, as you know, ultrasound lab here, so they can do very nice TCDs and flow studies, and I'd probably want to watch this.
Yeah, she had severe pain in her right upper extremity that was disabling, significantly disabling for her. And she had tried for over a year to get rid of it. She was on max doses of gabapentin, pregabalin without relief. And it bothered her so much that she actually had shoulder surgery, expecting that that'll get better. And it actually worsened after that.
Well, you can safely do an injection. So if the trial balloon on the right side, the left side looks like it's the more dominant. If the right sided trial occlusion didn't have a problem, I'd probably think about embolizing that and then possibly fusing it, not an ADR for sure. I don't know. What do y'all think?
Yeah, we did the balloon occlusion. She passed balloon BTO on the right side. Yep.
So since we're almost at,
I agree with you.
lead us out of here.
Yeah. No artificial disc.
Yeah, you know, even a foraminotomy could get you in big trouble there.
Even an
Somebody
injection could
wandered
get you in
there.
trouble there. Yeah.
Yep.
This is
So-
a great
So
case.
anyhow, so we did a little search on what the literature says. We found some cases about anterior and posterior indirect decompressions of this problem, and then we decided to do anterior. So in the interest of time, we'll just quickly go through this video. You know, I do a lot of carotid endarterectomy, so I'm very familiar with that approach. But Mike, why don't you quickly take us through the video? We have a lot of time left.
So we here have the C5-6 disc exposed. We are doing some periosteal dissection of the oncus of C6, bluntly dissecting over the transverse process of the C6 vertebrae till we find the anterior tubercle. We're doing the same thing at the level above, and this is really so we can fully unroof that C5 foramen. Here we got a nerve hook within the neuroforamen. This is here, gotta go back and look at that real quick. So C5 transverse process, the anterior tubercle of C5, the body of C5, and the nerve hook within the foramen. So then after we identify the foramen, we use a Kerrison to bite off the TP. We expose the vertebral artery. This here is our proximal vert. We're putting the nerve hook inside the C5 foramen. And then what we realize here is that the the loop was very adhered. So we did a kind of tailored foraminotomy. We're protecting the vert with a dissector, and we're doing a very minor lateral corpectomy of the C5 vertebral body. And then here we can see the Garrison helping us take out that lateral border of the C5 vertebral body and protecting the vertebral artery. So we can catch a glimpse there of the nerve, and we can see how compressed that nerve root is. It's completely plastered against the side of the C6 vertebral body and to the roof of the transverse process of C6. So we unroof the foramen a little bit more, and really this is just a few millimeters. And then we perform standard microdissection to release the artery. They were very thick bands, fibrous band and attachments to the bone, the nerve, and all the surrounding soft tissues. And look, in retrospect, if we would have done an ACDF to try to distract this with a graft, that would have been unsuccessful because this was very stuck, and it took a significant amount of microdissection to get the loop out. And just in the interest of time, we managed to release the loop. We can see how significant that loop is here. We're dissecting the vert off the C5 nerve to release it. And then we use Teflon to maintain a transposition of the vertebral artery. So there's a little piece of Teflon between the artery and the nerve, and then a piece of Teflon kind of creating an artificial floor. So now the loop is completely outside of the foramen. And the patient had immediate resolution of her pain post-op. And this is our final view.
Jesus.
And here we have a 3D reconstruction of our foraminotomy. So we can see how we really just drilled a few millimeters of the lateral aspect of that C4 body, and we're able to completely reduce that loop.
What a case.
Amazing, great case.
That's an awesome case. You should give her a neck tattoo in the front of her neck. No C4 corpectomy.
Yes.
Told her, do not ever get spine surgery from anybody else who doesn't know what you have.
That's
Great
really
case.
well, very nice to see, and very nice discussions and clinical mix also. Thank you so much. Please claim your CME credits. Scott, Rick, Jack, does one of you want to take us out from here?
Thank you.
Scott, why don't you do it? You've been more vocal.
Yeah. Well, no, this was a great session. That case at the end was I think something that none of us have seen before. Hope you'll do another journal club for us in the future.
Be great.
Thank you,
both.
guys.
Thank you
Having
very
us.
much for doing it.
Have a good weekend, everybody.
Thank you, you too.
Safe. Thank you.
All right.
Bye.
See you again.
Yeah, May the 4th be with you. Thank you, Cliff. Can't wait for our article. Oh, yeah. Hopefully get accepted and out there.
Okay, yes, I'm just signing off here.